will be on stenting technique. This is Dr. Ferenc from Bad Kreuznach in Germany that will tell us about how to treat bifurcation lesions. So that's lesions with big side branches.
Thank you so much. So my topic will be to present to you the data from BBK II trial on Culotte versus T-stenting for treatment of coronary bifurcation lesions. This is my conflict of interest. Study was completely supported only by our center. There was no support from any company. So what was the background for our study? If we treat patients with coronary bifurcation lesions, there is still a need for side branch stenting in 5 to 36%, just to achieve an optimal result. And we have at the moment, at least in Europe, we have two techniques which are frequently used. This is TN protrusion, so-called TAP stenting, and Culotte stenting. Two different approaches with the same message. We have to try to treat patients optimally according to the side branch stenosis. And there are no randomized trials comparing both techniques directly. And we randomized 300 patients, 150 to Culotte stenting, 150 to TAP stenting. As you can see, we have some small loss to angiographic follow-up, but still around 90% of patients got follow-up angiography, because this is an important point, because primary endpoint was angiographic endpoint. And we have complete clinical follow-up for all study patients. And this is primary endpoint. As you can see, the primary endpoint was statistically significant, favoring Culotte stenting with a mean maximal percent diameter stenosis of 21% after Culotte versus 27% after TAP stenting. And even a significant p-value was obtained after adjustment for some minor differences in baseline variables. And if we just take a look to the question, how was the binary in-stent stenosis rate, you can see there was a highly significant difference between both study groups. In Culotte stenting group, we had 6.5% binary stenosis rate, but in TAP stenting, 17%. And again, this was caused by the differences in the side branch, whereas in the main branch, binary stenosis was infrequent and not significantly different between two study groups. And the question is how it looks with target lesion reinterventions. And you see in this slide, target lesion reintervention of the bifurcation lesion at 1 year was 6% after Culotte stenting versus 12% after TAP stenting. So significant, so we just missed significance importance or significance level with a p-value of 0.69. However, you can see reintervention was mostly driven by the side branch. So in conclusion, we could show in this study that compared with TAP stenting, Culotte stenting was associated with a significantly lower incidence of angiographic restenosis. There was a consistent trend towards fewer target lesion reinterventions after Culotte stenting as compared with TAP stenting. And the observed differences between the two stenting techniques were driven by differences in the side branch result. Thank you so much. The study is also published online in European Heart Journal.
Congratulations. Excellent.
Questions? Yes?
Last row there.
Hello, Damien Coulon from Le Quotidien des Médecins. I was wondering how often is Culotte stenting used actually? What is the frequency of its use in heart service? And what are actually the rationale for the physician to choose between one technique or another?
So you should know, at the moment, in many centers, people, this is a general recommendation, all interventional cardiologists should try to treat coronary bifurcation lesion using one stent. However, in daily routine, we still need in 10 to 20%, we have to put second stent because of dissection of the side branch, because of subtotal stenosis, etc., etc. So then the question was, if we have suitable anatomy for both stenting techniques, the question was which kind of technique or which approach will be beneficial for the patients. At the moment, we mostly use tap stenting, kind of T-stenting. And many people, many doctors I know from many conversations, they are very skeptic to Culotte. And this study even just show that Culotte is safe, is even better according to the restenosis and according to the clinical follow-up. So there was a consistent reduction of target lesion revascularization. So it means doctors who are working in daily routine in the cath lab, they should now consider this approach if they have patients with suitable anatomy for both techniques. So this is what I'm now changing in my daily clinical practice.
I think two comments there. This is Culotte stenting done very well in a single center with obviously very experienced operators. You have 100% final kissing balloon. That's rarely seen because one of the problems technically is to get back into the side branch, very technical comment, and do the final kissing that defines the final conformation, geometrical conformation and coverage of the branches. So 100% shows there is operators there that know what they're doing and they're doing it in a very good way. But for that reason, it was very important to do that trial.
Yeah, exactly. So Andreas, your remark is perfect. So this is important point. You have to do final kissing balloon dilatation. This is obligatory part of this procedure, and we show, even I had one time experience, there was a patient without final kissing, and even next day there was problem with stent thrombosis. So we try always to perform final kissing balloon dilatation. That's why this approach is a bit technically more challenging, but if people are doing this, performing in daily routine this procedure, they will be skilled. That's the only question of
there's more questions there.
Lots of questions coming in.
François Schill for the Lettre du Cardiologue. Most of the restenosis occur on side branches, which are by definition smaller than the main vessel. And usually these restenosis are quite short. Did you assess by FFR whether there is some ischemia induced by this restenosis?
Yeah, we check it, our patients, we try to have a complete angiographic follow-up. As I told to you, angiographic follow-up was more than 90%, and what we saw, definitely, the restenosis was located practically in majority of the cases in the ostium, at the ostium. In tap stenting, in 80%, exclusively at the ostium, and by Culotte in around 50%. So it means we have still some technical problems with tap stenting to cover completely the ostium. And we saw even retrospectively, there are some gaps. We didn't perform in any cases, in routine cases, IVUS to know, to see is there some kind of gap or not. But we can say majority of patients had restenosis in ostial part of the side branch, and good news for the patient, we can treat this very effectively using drug-eluting balloon post-dilatation. So majority of the patients with the need for side branch stenting, if they had significant stenosis more than 75% and more or they had positive FFR measurement, we performed drug-eluting balloon dilatation, and this was working very nice.
So you're saying with culotte stenting, the technical benefit is you definitely get coverage of the triangle.
Exactly,
Whether with
the coverage.
TAP, even in your good hands, you might have missed
Right.
it sometimes. We have 2 more questions.
You may have addressed this, but could I ask a very basic question? Could you explain the difference, the fundamental difference between these 2 types of stents? Sorry, could you explain the fundamental difference between the culotte and
Yeah,
the T-stenting?
Yeah, exactly. So both techniques are according to provisional T-stenting approach. So our philosophy based to try to stent patients or to treat patients with one stent. So you can, usually if you use tap stenting or T-stenting, you place first stent in the main branch and then you open the struts to the side branch and implant a second stent in the side branch and do final kissing balloon dilatation. In the culotte stenting group, you have 2 options. You can go you can stent first the main branch, or you can stent first the lesion from main branch into the side branch, do kissing balloon for the distal part of the main branch, and then it's decision if you have good results, so you can let it, you can leave it. If you have dissection or residual stenosis more than 75%, then you can put 1 stent more. And then final kissing balloon dilatation is obligatory. So that's why, Andreas, you mentioned this correctly, we are a high volume center, and we do this routinely in 100% of cases.
Yeah, which is good. I think there is a nice diagram in the presentation slides that explains the difference nicely. You have to see it once to understand. We have 1 more question from TCTMD.
Mitchell Zalur, Cardiology News. First, and maybe this is in the diagram and that'll explain it to me, I hear the term final kissing balloon a lot before today, and I've never quite understood what it meant, so perhaps if somebody could briefly explain it, that would be great.
Yes, we can.
And also I'm wondering, based on the discussion you've had, if a operator or a center was not confident of their ability to achieve 100% of a final kissing balloon finish, should they not use this approach, and what should they do?
In general, you should, if you are a doctor, so you should in general try to use both techniques, but if you are not able to do culotte stenting correctly, then I think it's still better to do tap stenting. Better good tap stenting as bad culotte stenting. So, but of course, patients are expecting best treatment, and according to this data, if there is suitable anatomy for both approaches, you can achieve better results with culotte stenting, which is quite a more technically challenging. But doctors should be trained in this technique.
I think that is a fantastic final statement.
Yes.
A lot of I attended a session in the United Kingdom where we asked the audience, after long elaborate discussions about culotte stenting, crush stenting at the time, and we asked who has done a culotte stent. It was 5 people in the audience. It's not very well practiced, but once you use it routinely in your center,
Yes.
you get to rely on it, and you know the tricks. And there was one final question so we conclude with the final kiss. The final kiss, for your information, means that you have both wires back in the main branch and in the side branch, and you use 2 balloons and blow them up at the same time so that they are very close together like a kiss. That ensures that all the deformation that happens with going through side branches, blowing up one stent, pulling the other in this direction, those deformations are corrected so that at the end you have 2 tubes and you have the best possible alignment of the stent and the best possible apposition. And on that note, of course, looking into the future, there was another technique that actually uses two kissing techniques, double kissing crush. Is that the next trial that you will be doing? Because that shows very promising results. More kissing, even better results.
Yeah, maybe you're right, but we have only, at the moment, we have only one study with head-to-head comparison between Culotte and double kissing crush. However, in distal left main, and we have all-comer bifurcations patients in this study. So it will be interesting to repeat such study in non-distal left main bifurcation patients. Thank you so much.
Yeah, and you, of course, if you